Welcome to the panel discussion on diagnostics. I hope you've had a chance to make some new connections with other delegates on the platform and build on existing connections. In October 2021, the government announced a £350 million investment in 40 new community diagnostic centres. The intention behind this investment is to help patients get earlier diagnosis by providing easier, faster and more direct access to the full range of diagnostic tests required to understand their symptoms. Increased patient diagnosis will help reduce waiting times by diverting patients away from hospitals, allowing them to treat urgent cases while community diagnostic centres the backlog. Well, to help us understand and analyse how effectively implementing changes will help to decrease the NHS's ballooning backlog, we have on our virtual stage for you Professor Paul Foster, NIHR Biomedical Research Centre, Moorfields Eye Hospital, NHS Foundation Trust and UCL Institute of Ophthalmology. I was worried I was going to be able to say that this morning. Dr. Harry J. Moorfields BRC, and Danny Joseph, Programme Director at the Black Country and West Birmingham Acute Provider Collaboration. Don't forget to try and use the Q&A function to be included in the conversation. You can find it at the bottom of your screen, or maybe I think it's actually on the right of your screen. And of course, you can share your thoughts on Twitter with our hashtag NHE365. So we've got another full house for panel 2 this morning. Welcome to Danny, Paul and Harry. Great to see you all. And thank you for making time, because I know it's, your diaries are packed right now. So we do appreciate you joining. Danny, demand for diagnostics was rising year on year before the pandemic. What impact has COVID had on diagnostic waits, over the last 2 years? Where do we find ourselves now?
So, you're right, diagnostic waits were increasing before COVID and the pandemic actually started, and a lot of that was around workforce challenges and around increases in demand, both in terms of acute diagnostics as well as elective diagnostics. But I think COVID had a very significant and major impact on making that a lot worse, a lot faster. Thinking back to the first wave of COVID, actually anything that wasn't cancer or urgent treatment was stopped based on national advice. And that meant that actually, a lot of imaging departments, a lot of diagnostic services were unable to do what they normally do, and also not getting any of the referrals through from GPs. So, if you have a look at performance on diagnostic waits, around the January, February kind of quarter one of that year, we go from being at around kind of 98, 97% to just under 60%. So, there's a really significant drop. And obviously we spent the last 2 years trying to get that back, but that's been incredibly challenging because, again, those workforce issues haven't gone away. The demand has actually got much worse, because in addition to your normal growth in demand, we've then got all of the demands that we would have expected to have seen during that time. And it's just made it such an incredibly acute issue at the moment, especially seeing as diagnostics factors into every part of every single pathway at some point.
We're going to kick off in a minute, Paul, with you on the Hercules Clinic. But before that, Harry, how has it been at Moorfields, just following on what you were saying?
I completely agree with Danny. It's the system for ophthalmology, which is predominantly diagnostics and outpatients, to be perfectly honest, was bursting, and if not broken, even prior to COVID. There were several national investigations into patients that had lost sight due to delayed follow-up, and it was a real national priority even before COVID came along. But then, at Moorfields, we're obviously one of the biggest eye hospitals in Europe, if not the world, and just within the glaucoma service alone, when the pandemic started, we had to cancel 50,000 appointments. So that was 50,000 literally wiped off the slate. And then it was a case of how do we prioritize who needs to be seen to stop people losing sight, and that was a real challenge. We were lucky at Moorfields because workforce is less of an issue for us. Within the glaucoma service alone, we have about 28 consultants. We have almost 80 to 90 specialist optometrists. So we have a pretty good infrastructure, but we still struggled, and we realized that the only way to see patients safely and prevent and stop preventable sight loss was really to think about new models of working, really tear up what we'd done before and start from scratch. And being honest, that was the only positive of the pandemic, I think, is that we had a blank canvas whereby we could redesign our services, start from scratch, and see how we could make things work.
You made my blood run cold a bit there, Harry. I mean, gosh, you do realise when you say that, you had the risk of people losing sight, that just really brings the nature of this crisis and the challenge that presents you all in the healthcare profession just really, really home to me. I mean, Paul, I'm guessing that part of your solution was the Hercules clinic at Brent Cross, a pop-up diagnostic hub, if you like. Tell us a bit about the clinic and how that fits in with how you and Harry and the rest of your team are trying to cope with the diagnostics backlog.
Well, we very rapidly decided that we had to reconfigure our services, both in terms of patient safety and staff safety and efficiency. And we were fortunate that we had started the groundwork back in 2014 because the nature of ophthalmology being the busiest outpatient speciality in the NHS is we're always looking at the numbers of patients that we can see and trying to improve the efficiency. So we had built on research work that I've done through my role at UCL, where we examined large numbers of people in the community, and we found that we could do research examinations doing a full eye test in about 10 or 15 minutes in the community. For instance, UK 500,000 person study that's been running in the UK since about 2006. We helped design the eye examination for that, and the brief was to do a full eye examination in 10 minutes. Wow. In hospital, it was taking us more like an hour and a half. And so, the question was, why can't we replicate in hospital what we're able to do in a research environment? And then that led on to setting up what was termed Clinic 1A in Moorfields, where we converted a waiting corridor into a clinic where patients went down a sequence of examination stages, coming in at one end and leaving at the other. And so the idea of this sort of one-way flow down a sequence of equipment was born there. And we had done quite a lot of the foundational work in 2014, 2015. Then when we went into the pandemic, the concept was to that type of system, also to explore ways to make the operational process more efficient, to try to look at ways of maximizing staff and patient safety, and also to bring some technological advancements into the process, and just look at ways of making technology work for us to help us see more patients more quickly and safely.
And just to be clear, Paul, are you seeing NHS patients in the clinic, or at the moment are you just using it for research purposes?
So it's NHS patients having their routine eye tests. Yeah. And in the process of doing so, we're monitoring the way that they move through the system, and we're actually rearranging the clinic every few weeks to compare the sort of the flow of patients and the efficiency of movement for staff and patients through the clinic. So yes, it is NHS patients having their routine services, their routine testing done at the same time as taking part in research.
I can see just from your smile, Paul, that it's been very satisfying, I'm sure, for you doing that and seeing it work. So we'll come back to a bit more depth on that in a minute. But just bringing Danny back into the conversation. I mean, what's the national strategy, Danny, for reducing diagnostic waits, and how are you implementing this locally? And she's going to throw another question in, which is bad journalistic form, but just for good measure. And are you having access to any of these diagnostic community hubs in your area?
Yeah, so it's great.
Three questions at once, Danny. Sorry, that was really bad.
That's fine. Let's see if I can remember them all. Okay. It's great what Paul was saying about how you started with your community, with your model in 2014, because I mean, these things do take a bit of time. But in 2020, Professor Sir Mike Richards did a review of diagnostics after the COVID pandemic began, and made a number of recommendations as to the national strategy, and community diagnostic hubs and then community diagnostic centres, when they went through a bit of a rebranding, was one of the real pinnacle elements of the Richards review. We're really lucky in that actually there's been national funding to implement these across the UK. We submitted funding and have 2 community diagnostic centres up and running in the Black Country. One of those is within the Dudley area, it's Corbett, and the other one is just outside the Black Country at Cannock Chase Hospital. And they have both been running incredibly well. We've managed to get lots of additional capacity. Patients seem to really enjoy it. The parking's much better in and out of an acute hospital trust. And our longer term strategy in the Black Country is to go up to 5. Hopefully we've got another 2 opening in 2023, which actually were part of a longer term kind of strategy already. And we would really like to build one, because we've got a little bit of a patch in the middle of our area which isn't particularly well served. We would like to build something brand new there, money depending, obviously. And I mean, they've been working incredibly well. The next step is trying to work out how the additional capacity works with pathways. So do we have all of our Council one-stop clinics there, so patients can come, have their outpatient appointment, have their procedures, diagnostic tests done at the same time, and go, possibly with the diagnosis on the same day? And how do we make sure that actually, if we need to be flexible about capacity within our area, we can do that? I'd say that's probably one of our bigger challenges at the moment, because IT interoperability has always been a challenge. And the way we set up our CDCs was that each of them are aligned with an acute trust as a host. We would love to be able to have flexibility between the IT systems, between all 4 or 5 of them. We're not quite at that stage yet, and I think that would give us even greater ability to use them than we currently have at the moment, because what we are finding is that the areas that do have those, actually they're doing very well in reducing their waits. For those that haven't quite got them yet, that's still a bit of a struggle.
Is there anything that Harry or Paul you can add that would help Danny's challenges there?
I think our IT infrastructure has been a thorn in the side of the NHS for about 20 years. Progress is being made, but it is a limiting factor. For example, in ophthalmology, we're a very data-driven specialty. So, at the Hercules Clinic, when the patients come, they have a quite intense sort of diagnostic imaging and measurements and various parameters that are collected. The challenge is then how to review that data. Now, within our hospital, we have the infrastructure to facilitate remote review. People don't have to be on site to do this. But one subtle improvements in IT would, in theory, enable access to the 100+ consultants at Moorfields and the infrastructure we have to any region in the UK, if the data could be shared appropriately. And these sorts of models are what we would really aspire to, is to have ideally consultant-led care for all patients within the UK. Now, that means consultant oversight, and we really need good, solid IT to be able to do that. And I think that's a work in progress, really.
And Paul, really, I mean, what you're doing wasn't pandemic driven, was it? You're building on a decade of research, which led to this diagnostic hub.
We were incredibly fortunate that we had been doing the groundwork well in advance of setting up Hercules, and so it was a natural continuation. But the way that we designed Hercules as a research endeavour was focused on the needs at the time of the pandemic, and also need to come afterwards. So it was a continuation, but it was tailored to fit the requirements of the moment, and what we hope will be the next 10 years. We will be able to address the needs of patients in the NHS over the next decade.
And I guess other sectors, Paul, of the NHS can really learn from your research and take a lot of what you've done, obviously with your specialty of eyes, but use what you've done and your learnings to build other diagnostic hubs in other areas, a bit like Danny talked about. I mean, I would imagine for things like cancer and things like that, perhaps even patients might prefer going to a diagnostic community hub without that kind of fear of walking into a hospital. I can see so many benefits for how these might work really well.
Yes, so Hercules is based at Brent Cross Shopping Centre, and the attraction of thousands of free parking spaces with a coffee shop and plenty of restaurants and some retail distractions as well makes it for many people a very attractive environment to go for healthcare testing. Obviously, it doesn't suit all patients, and those with the needs for the services of an NHS hospital will still go to a hospital. But I think for many patients, having monitoring services, it's an ideal arrangement. And we're able to draw on the expertise of many different departments in UCL. We've collaborated with our architecture department, the Bartlett School of Architecture, engineers, mathematicians, business modelling specialists, and that everybody is very excited to be doing something that, from their own specialist perspective, they feel is unique. The architecture aspect of the project, we keep being told by our colleagues, is unique. Apparently, nobody's ever done this sort of process to design the environment around the needs of the testing for maximising the patient experience efficiency, while trying also to address the safety concerns from a research perspective. So we do feel that we're treading new and exciting ground.
Do you feel that as well, Harry, you know, with the design of these hubs being movable, flexible, presumably sustainable? I mean, is this kind of, are we seeing perhaps the future of NHS eye care, is certainly in terms of diagnostics moving forward here?
I think so, definitely. There's just one point I just wanted to come back to, which was the fact that, let's say Danielle mentioned that they have diagnostic hubs available, which has been fantastic. We're lucky to have Hercules and the smaller one that was set up just at the start of the pandemic. The other major advantage of these is that we're able to create capacity within existing NHS hospitals at the moment. So, for example, pandemic, virtually all cataract surgery was cancelled because it wasn't deemed to be urgent. So there's a huge backlog in the London region and across the UK for cataract surgery, and there's a lot of work going on a national level to try to increase capacity, etc., to let these patients be seen. Now, because, let's say with Hercules, we're seeing several thousand patients per week at Brent Cross, we've now created space within Moorfields hospital estates, so other patients who would need to be seen in a face-to-face setting are able to be seen as well. So this is an added bonus. We're not just able to deal with the backlog in the specialty that's being seen at the hub, but we're able to create extra space for other patients to be seen as well. I do think it is a move forward to the future, and I think this is something we realized quite early on during the pandemic, is that, you know, our traditional model of face-to-face clinics with laying on of hands is not necessarily viable for the future. And I know that at a national level, this is something that the NHS is keen to try to sort of communicate and disseminate with patients, because ultimately we have to look after patients in a method that they are happy with. Now, if you took a survey and asked, 50 patients, would you rather be seen in a diagnostic hub, or would you like to see, Professor Foster in person and have his personal reassurance? It's very difficult to approach that, because it's a real culture change. This move towards remote consultations, to traditional face-to-face care. But I think we as doctors and healthcare providers need to work with patients to try to help people understand that in reality, it's the only way that the NHS can provide sustainable care in the long term. And this is something that we will have to adapt to and change to after the pandemic. But I do think it's here to stay.
It sounds like you're adapting in a very, very positive way, actually. I mean, Danny, we talked a little bit, didn't we, about patients and perhaps how patients are. You mentioned the parking, which is a big thing when you're going to a hospital. We've all been stuck in the car parks or trying to find a space. What about the key challenges that the workforce faces with the diagnostic specialities? What have been the things that you've seen that have come out of the last 2 years there and that you're now tackling?
Well, diagnostic radiology is a major pinch point for us, both in the Black Country and actually in the wider West Midlands. And I'm sure nationally, actually, I'm sure there isn't an area of England that isn't dealing with diagnostic radiology workforce issues. The initial setup of our CDCs, actually, we worked with the independent sector quite heavily around mobile provision, but that's not necessarily going to be a sustainable model for the long term. I mean, CDCs may develop in that kind of split model or pure ISV, but actually we still have a major gap in our workforce. And unfortunately, I think we've been a bit slow off the mark to try and work out alternate ways of training and encouraging people into the profession to be able to expand at the rate that we're trying to expand at the moment, which we need to do, but we actually don't have the people in those professions right now. So we've recently done a piece of workforce modelling, having a look at newly qualified radiographers coming into the Black Country and how many we need, both in terms of maintaining our current standard of service and then increasing to include CDCs and lung health checks, which will be coming in nationally. And we need to at least double the amount of newly qualified radiographers coming in every single year. For the first couple of years, we probably need to triple it, and then it evens off after about 3 to 4 years.
How do you do that though, Danny? I mean, how do you can't just magic them up, can you? It's very difficult.
No, and the undergraduate program's 3 years. A straight direct entry apprentice program is still 3 years. It's going to be a 3 to 5 year process to get the correct number of people into that workforce. I mean, we can look at how we keep people, because turnover rates are really high at the moment, both in diagnostic radiology and I think generally in the wider NHS. 2 years of dealing with a pandemic and everything that comes out of that. There's a lot of people are tired and there's a lot of morale issues. So how can we make people feel valued and keep hold of them? We probably need to have a bit of a better look at international recruitment as well, because I think for radiographers, that's not really been something we've done locally. We've tended to focus on kind of local staff. But other than that, we need to think about, right, what training programs can we develop ourselves? Not relying on undergraduate programs, but looking at innovative models. So in our region, West Midlands Ambulance Service have an apprentice program as well as an undergraduate student program. And they make sure that every single year there are the right number of paramedics recruited, trained, to be able to put into new posts every single year. And they've got about a 95% rate converting from students into paramedic posts. They grow and train their own workforce, and that's what we need to be doing. We need to be becoming more self-sufficient with that.
Gosh, that's fascinating stuff. And I hope all that word's getting through to, sixth formers and universities as well, because in a way there's a real positive, isn't there, that you're coming out highly qualified and there's a need for you in certain jobs. I mean, Paul, how does it work for you at Moorfields? And, do you have the people you need, or do you face shortages in certain areas?
So, yeah, I mean, it's something that we've been involved with for many years. UK Biobank pioneered the rapid training of staff to do research health examinations, taking people who had no healthcare background, training them up to do, in many cases, quite technically complex examinations. And so we knew that it was possible to rapidly train people to do diagnostic testing in ophthalmology. And probably the group fastest out of the traps at the beginning, when we broadly conceptualized the needs as people, process, and technology, and that the people component involved rapid training. We were very fortunate to have an extremely dynamic group of individuals led by Professor Nora Colton UCL, who was our Director of Education, and together with Gordon Hay and Kerry Tinkler at Moorfields, they put together what's called an ophthalmic technician boot camp to train staff from no healthcare background to being able to carry out these technical examinations within 8 weeks. And it's really one of the great HR department pulled out all of the stops, and fortunately had contacts in all the right places to develop this very, very rapidly from the Docklands Nightingale Hospital. Our director of HR, Sandy Druitt, sort of had the bare bones of it all sort of ready to go. So we were lucky to be able to expand the workforce. And Harry, in particular, has worked very hard at keeping the staff engaged and running ad hoc training sessions for them. So, Harry, you've led more of that than I have. So, do you want to say a few words?
Yeah, I mean, it's interesting because one of the big impacts of the pandemic was that a huge amount of the population had turmoil in their workforce or careers and lost their jobs. And obviously for healthcare, we're looking to expand and train up new people. And one of the core skills that we want people to have is those human social skills. One of our early collaborators, who's actually a patient, said to us, at the end of the day, when I'm on a plane, the cabin crew somehow make me feel safe in a piece of metal surrounded by kerosene at 37,000 feet. So that's a skill set. And that was the kind of model that we were looking for, is to try and find people that had human skills that could put people at ease. Because engagement with any sort of healthcare setting can be quite anxious. Just to put patients at ease and allow them to be guided through the pathway, and that was the aim of things. So when we went through these waves of recruitment, there was one overriding theme that I noticed, and we sort of we went the extra mile just to sort of engage with these guys, because and I tried to sort of say to them that the Hercules project couldn't happen without them, because they a common term discussed around the pandemic was the NHS front line. And I said, look, you guys are the front line for this project. You are the patient facing group for this project. So the success is entirely dependent on you, and we trust you with this. And the overriding theme that we found from the people that joined us to work at Brent Cross, now these guys came from hugely diverse background. Many were in service industries, some were in entertainment, retail, a whole cross section. But the overriding theme from these guys was that they'd seen what happened during the pandemic. They were so proud of the NHS and they wanted to be a part of it. And it actually brought a tear to your eye, because we by the end of the pandemic, we were all disillusioned and shattered and exhausted. But these guys were just bursting with enthusiasm, wanting to give back and contribute. So that was their overall their real driving feature to take part.
Wow.
As well.
That's a credit to you, though, Harry, for and you and your teams for making them feel like that.
And it's their transferable skills that they have. Yeah. Like Paul said, you can train anybody to do the technical things, but you can't. It's very difficult to train someone to put another human being at ease. So I think that's something that we've been quite fortunate with, especially with the training program at UCL, this sort of boot camp. That's it really has helped us ramp up the workforce, because like Danielle said, it can be, the pipeline is a real challenge.
Yeah, I did a little bit of that, just digress slightly, and then I'm going to give Danny the final word. I did a little bit of that in Hull Royal Infirmary in the A&E department the other day. The receptionist was on a double shift. She was snapping at people. There was an old man with no hearing aid in who thought he'd bleeding, who thought he'd missed his appointment because he couldn't hear. There were lots of things going on. So I was looking after my mum and decided to use my journalistic skills. And you almost felt that it needed somebody from a charity to do that job and go around, just check everybody was okay. And it was really satisfying trying to kind of help out and use hopefully some people skills. Anyway, I don't know why I'm telling you that, but Danny, what strikes me today, just final word before we move to our next speaker, is, we all mention the word collaboration a lot. I'm just wondering how trusts can work together. I almost kind of want to get you and Paul and Harry in a room together. You can just from our half hour, how you can all help each other with thoughts. Collaboration's key, isn't it?
Yes, and you know, I'm program director for the Black Country Provider Collaboration. So in all ICSs or regions, people are trusted and organisations are being encouraged to work together. But you're right, actually, how do we collaborate on things nationally? Because some of the stuff I've been hearing from Paul and Harry has been absolutely fantastic, and I've got ophthalmology teams that I know would probably jump at the chance to understand your models a bit better. I think you know, webinars and panels like this are really useful for making connections or understanding what's going on where. And you know, just working on a much wider footprint than we're used to. I mean, we're coming out of probably the last 15 years worth of having to be competitive with each other to trying to switch to completely the opposite tact and work together and be collaborative, which is great. But we need to build the networks, and yeah, you know, they're always developing and growing.
Good. Well, I'm sure you've got Paul and Harry's details now, and you're connected. And that's what's lovely about hosting these virtual events for me, is watching how our audience, you know, come together and can have access to experts in their field. But you've been a pleasure to chat to. Our time is at an end, and I do hope you'll perhaps be available to come on one of our other NHS virtual panels and update us on how you're doing in a few months' time. Thank you so much. Brilliant panel. To continue the great discussion, we have Dr. Kevin Smith, President and CEO of University Health Network, Canada's largest academic health sciences centre, she says, putting her teeth back in. Educated in Canada, the US and Great Britain, Kevin is passionately committed to the mission of education, research and exemplary clinical care. So please welcome Kevin, who sent in a pre-recorded presentation to help us explore the healthcare backlogs further.
Hello to all my friends in the United Kingdom, and thank you for the opportunity to speak at this very important conference on the NHS backlog. My name is Kevin Smith, and I work at the University Health Network in Toronto. I know after coming through a worldwide pandemic, one of the last things you'd like to hear about is the word opportunities, but unfortunately we're here to talk about those, particularly as they relate to catching up on the backlog of activities, be they surgical, procedural, diagnostic, and otherwise. Clearly in both of our nations and around the world, this pandemic interrupted everything. Our scheduled care, our unscheduled care, all parts of the healthcare system, every facet of social life and civil society. And clearly the recovery efforts will also need to affect that as well. In my province, where we have almost 15 million people residing, the province of Ontario, the Ontario Medical Association has estimated that there are approximately 20 million patient encounters that were delayed or missed during the pandemic. Not every one of those will be replaced, but many of those will. We also are concerned by those missed appointments in terms of what it means for more advanced illness, particularly in diseases where latency could lead to a worse outcome. For all of us, things like surgery, cancer screening, immunization, mammograms, colonoscopies, diagnostic testing, etc., clearly has a very significant lift ahead of us. And at a time when I don't think we can have this discussion without considering just how tired our staff are. These are people who've worked very hard over the last 2 years. And as we think about recovery and think about catch-up, it is really an equal balance of how well will we measure and manage the risk to our staff, as well as further delays, risk to our patients. And I believe that's something that we will continue to dialogue on and explore best practices together. Most of our providers in Ontario believe that the delay has resulted in worse health outcomes and will result in many more in the future. Something that we obviously will study, challenge, evaluate, and measure from a research paradigm. When I think about what some of the opportunities realized or learned from the COVID pandemic, I'd like to focus on a few with you in the brief time we have together. First, the opportunities around how we'll address surgical care and the suggestions that we've learned from surgical smoothing to make the operating rooms more efficient by about a 10% gain. Second, the application of digital technologies and virtual technologies. We've particularly focused on this in a virtual emergency department. And third, the importance of the health professions and re-examining who does the work that's required, both for current work and future work, in a world where we know we simply can't hire as many people as will be retiring with nursing backgrounds and other allied health professionals. Let me start by talking to you about work we did on surgical smoothing. Fortunately and serendipitously, we began this work about 15 months prior to the pandemic beginning, and we did so working closely with the Not-for-Profit Institute for Hospital Optimization. Working with that group and looking at scarce resources, we questioned how might we provide additional services within the same resources for our surgical patients and provide better access for our surgical colleagues to meet the needs of their patients. The operational approach really streamlined our care, and as you know, is often referred to as surgical smoothing. We found that most elective surgeries at University Health Network and elsewhere are often scheduled between 8 a.m. and 5 p.m., with emergency surgeries, of course, coming in unpredicted and unregulated fashion, as one would expect. We also noted that many hospitals, ours included, often combined the rooms where urgent care and emergent care was occurring along with scheduled care. And our work in surgical smoothing has demonstrated to us that by separating that work, holding a number of rooms constant for emergency work, and continuously and effectively operating an additional number of rooms for scheduled predictable care, carefully monitoring the length of each case, and allocating the length of time required more appropriately, we could in fact, and did in fact, gain about 10% efficiency with our surgical time. Continuing to expand that is going to be particularly important, not only from a fiscal perspective, but I actually believe more importantly from a health human resource perspective, expecting our colleagues who are very tired after this pandemic to come back and potentially function at 110 or 115% throughput is likely to be folly, and we need to worry about their health and well-being before even suggesting such an opportunity. That really means for us reconsidering how we do that work, what kind of data we need to evaluate our performance. In doing so, we've put in place a surgical tracker to monitor our postponed surgeries, to evaluate it when we bring them back, and to again look at the how advanced their illnesses has grown since the original referral. We also are looking very carefully at how many more surgeries we can do using surgical smoothing. And we believe that with extended hours and the appropriate recruitment of staff, both regulated and, as I'll speak to in a few moments, unregulated extenders, we can take our roughly 25,000 surgeries a year to 50,000 surgeries a year. And we look forward to doing so. A few other ideas to clear our surgical backlog. For us, at the height of the pandemic, we were behind about 5,000 cases, particularly surgical cases at University Health Network. By implementing our surgical smoothing process, we have seen our OR hours also increase by 13%. So on full, a 23% gain, 13% plus the 10% we gain by efficiency of smoothing. We also have seen the use of additional space, a previously vacated cath lab, for example, and a number of rooms converted to procedural rooms and moved a number of procedures like hand procedures and others which might historically have been done in operating rooms to those procedural rooms with a different staffing ratio, so that we were in fact again able to do more patients in the same amount of time. We also saw the partnership with a local clinic to take out of hospital a number of interventions, including colonoscopies, so that we again could catch up more quickly, again with time and latency related illnesses that a worse outcome could be realized without intervention. Let me comment, if I might, on the backlog of lab and diagnostic imaging. For us, it was really about changing our imaging protocols to reduce the scan times. This happened between the second and third wave of the pandemic as we saw particular challenges both with staffing and access. We also, in doing so, did away with oral contrast during CT prep to avoid people waiting in waiting rooms and again, maximize our flow. We opened on weekends and evenings, and fortunately we were able to find staff to do so, which I suspect will be your and our greatest challenge going forward. We're also investing in separating our inpatient delivery from our outpatient care in imaging as well. For too long, those have been convoluted in the Canadian healthcare system, and we have put in place new teams who can focus exclusively on either inpatient or outpatient work. Should one find a valley, the resource would be deployed to the other area immediately and in real time. Let me chat with you for a moment about our advancement of integrated care. And for us, integrated care really has meant taking what was once an acute care end of inpatient episode and the home care experience and really blurring it into one. So discharging patients literally from the earliest point on the North American continent and melding their home care with the end of that post-acute episode, marrying that with digital health, virtual care, and regular communications, both virtual and real. We launched our first integrated care initiative in thoracic surgery in June 2019, mostly for those undergoing lung surgery, often lung cancer. We, in doing so, had three things in place that I think are essential. One, a group of nurses who were trained not only in the acute care episode in hospital, but overseeing the discharge process and the care at home. Two, a 24/7 single telephone number that anyone could call at any time when they had a question. What we saw over and over and over again with the bifurcation between hospital-based care and home care was a confusion as to who to reach out to. And in this case, it was terribly important that the individuals could reach out through one central number. And the person answering that phone then had a process by which they would activate the right provider. The right provider would then respond to them. The unsung heroes of this model are what we would refer to as our personal support workers, the unregulated home care providers who often keep our system afloat. Those individuals, when attending the patient regularly, came to know them during their home-based experience practically better than anyone else in the care team. And they were able to very much note a change in their demeanor, a change in their medical stature, and reach out immediately to one of the regulated health providers, in our case, a nurse navigator. Made a tremendous amount of difference. Similarly, the nurse coordinator of the program would then deploy the appropriate home-based provider, be that a respiratory therapist in the case of our lung program, or other healthcare provider to the home with assessment. An incredibly important enabler of this was a single digital home-based record to complement the hospital record. We're very conscious in not trying to reinvent the wheel and to go with what I'll call a cheap and cheerful solution, out-of-the-box solution, that really did, however, allow us to make sure that all of the notes and information required by home-based providers could be captured, and that the appropriate information could then be shared with the hospital-based team. Interestingly, it was a reasonably small amount of information that overlapped. Since the launch of our first program, we've gone much more broadly across UHN and are now working with our funder, the Government of Ontario, through Ontario Health and the Ministry of Health, to secure additional hours of home care professionals to work with us. Again, not separately and discreetly, but as a single payer, the hospital, engaging those individuals to work with us to ensure that the delivery of that care could be done in a way that is really one continuum with one outcome through a single payer with home care and hospital-based care, truly a seamless continuum. Two last areas, if I might just briefly touch upon for us that's made a big difference. One is a virtual emergency department, something that we talked about for a very long period of time. This came into development in the summer of 2020, and it actually came about as a result of a significant dialogue with infection control as well as the emergency department personnel. The idea really was for those with urgent but non-life-threatening conditions to be able to be seen through the virtual emergency department. In Canada, access to primary care was significantly constrained during COVID, and many more patients after wave one, where we saw a significant decrease in the number of people attending EDs, it actually rebounded. And for us, it was very important to find a way to bring the minimal number of people required to limited physical plans. That meant selecting some technology that allowed us to see people on their phone or computer or personal assistive device to ascertain whether or not they needed to present to the emergency department and to follow up with either a prescription or diagnostic testing as required. Fully 3/4, 75% of people we saw in our virtual ED did not require presentation to the emergency room. It's something we look forward to continuing to work on and would be more than happy to share with you more details following your conference should anyone have further interest. Virtual care, I should say, is not intended to replace the emergency department, but be an augmentation to it and to good primary care. The primary goals will and continue to be providing good patient care in an efficient and effective model. I'd also say it reflects the expectations of a changing patient demography, with younger people being very focused on a more transactional experience than we've historically seen in real time, with outcomes being rapid and easily available. More to come on this one, I hope, in the very near future. Last but certainly not least, let me give a shout out to our colleagues at the Michener Institute for Education at UHN. As I mentioned, we're the only hospital with the privilege of operating such an institute in Canada. And the institute very quickly during the pandemic was approached by the Government of Ontario and the Government of Canada to think about how could we use online training to allow a number of health professionals to work in different domains. 3 areas immediately came to mind, which we rapidly mounted programs in. For wave one, it was those who were not used to working in critical care environments, but who wished to support their colleagues who were critical care experts. So we literally had thousands of nurses and physicians and others across Canada, we opened this up well beyond UHN, sign up to actually get a feeling for what some of the needs, skills, and abilities of care extenders in an ICU would look like. Very proud of how well that went. Secondly, we saw people who were very challenged and deeply needed in long-term care. And again, many of our colleagues at University Health Network who put up their hand and volunteered to do work in long-term care because it truly was the epicenter of the disease in Canada in the early waves, had never worked in long-term care. So again, they were able to be oriented to, come to understand, have IPAC training, be more aware of what frail elder needs look like and what care needs might be necessary. And we're able to be deployed to long-term care very effectively and in very real time. It made a huge difference to our partnership with long-term care, as well as to avoiding patients being unnecessarily transferred from long-term care to acute care hospitals at a time when our capacity was significantly challenged. I personally believe one of the most exciting things for the Michener Institute to do now and into the future is to think about those care extender roles. So taking the work of nurses and RTs and OTs and PTs and others, and actually looking at how might an unregulated extender help support them. That process has begun. We've asked a number of our colleagues to come together, not in any way to diminish the remarkable and unique roles of the regulated health providers, but to in fact augment them. We know simply based on retirement projections and training that we can't recruit enough people to do work the way we've done it historically. But with the Michener and with virtual education, we believe there are many solutions, and we look forward to not only working on those, but sharing them with you, our colleagues in the NHS and beyond. Let me wrap up by again thanking you for the opportunity for chatting with you, for talking a little bit about some of the initiatives that we've begun at University Health Network, and to congratulate you for the stupendous work that you've all done during among the most challenging years of all of our careers. I know it's forced us to think differently, and the future will expect that of us. But in doing so, I know we will all keep in mind the privilege we have in caring for patients, the responsibility we have in training the next generation of healthcare professionals, and the opportunity we have to contribute to scholarly research and translate that into practice. I hope you enjoy the rest of your meeting, and thanks again. Hello to all my friends in the United
Well, thank you to those who joined me on the stage, and to our excellent keynote speaker, Kevin, there, who contributed from Canada. And last but certainly not least, thanks for staying with us for that. Time for another very quick break to re-energize ahead of more great thought-provoking conversations to come. This is your opportunity to discover our NHE365 platform, inclusive of the digital marketplace and on-demand content, as well as the networking functions you may have used in our first break. So let's just have a look at the time here. If we can see you back for just before 11:40, that gives us a quick 5-minute breather. Thank you. Great. So if you can